Descriptions.
So yes, so today I'm going to talk about security in health informatics, and especially I'd like to focus on how a secure electronic prescription network can be established. And I'm a first-year master's student in computer science. My research interest is in quantum computing as well as cryptography and network security, and that's why I'm studying this topic today. And first, we'll take a look at what the computer and network security means, followed by a little bit brief look at the HIPAA, which is privacy laws regarding health informatics, health information in the US. And then we'll take a look at how our prescription is filled, followed by literature review, and how the e-prescription gets filled, and how to establish the secure e-prescription, and future direction and insights and reflections. So as we saw this before the last time I talked, there are 6 security concerns and 4 security threats. The important things in e-prescription is confidentiality and authentication. Confidentiality so that the patient prescription record is confidential, and authentication so that when a doctor sends an e-prescription to a pharmacist, then the pharmacy has to know that it is really from the doctor. So we have HIPAA, which is American privacy laws, American laws regarding the patient privacy laws. And we have 3 covered entities, in particular healthcare provider. For e-prescription, it refers to anyone who prescribes a medicine. And then prescription in general falls under the category of protected health information, because if you look at the prescription record, you can easily identify who wrote the prescription to whom. So according to HIPAA privacy rules, then the patient has to know what's going on with her prescription record. And HIPAA also has the security rules. So how do we get our prescription filled? In the old way. So we have a patient, goes to see a doctor, and a doctor writes down a prescription using a pen onto the prescription pad, and then the doctor gives this to the patient, who then goes to see a pharmacist. A pharmacist dispenses that medication to a patient, and then later pharmacist contacts the health plan or insurer to get the prescription fee reimbursed. So from patient's perspective, then, as we said before, that the main concern is that the prescription, what kinds of medication was prescribed to a patient, must be confidential. And however, many companies sneakishly collect the data from the prescriptions so that they can make a decision on hiring or promoting process, which is very bad. From the doctor's point of view, then, a doctor doesn't want to let unrelated people know that what kinds of prescription that they wrote to a patient. However, some of the HMOs collect those data and compile a guideline as to what kinds of medication should be used, and sometimes incentives are involved, and it is really a conflict of interest. From the pharmacist's point of view, pharmacists are required by the laws to collect data about patient and doctors' identities, so that just in case when there is a legal investigation, then legal enforcement officer can know who wrote the prescription to whom. From an insurance perspective, they actually they collect or purchase the pharmacist's data from the pharmacist, of course, and using those data, they make a statistical analysis as to what kinds of drugs are popular, and once they found those popular drugs, then they buy them in large amounts so that they can get a discount. Matthias studied about how to protect a doctor's identity in prescription information. The idea is, at the pharmacy we have one data that maps doctor's name to a prescription information, but the pharmacist splits the data into two sets of data. The first set is a mapping from the doctor's name to the anonymous doctor's reference numbers, and the other set of the data is the prescription information, maps the prescription information to the doctor's reference. And the first set of the mapping to the doctor's name to the reference numbers gets sent to the trusted third party, and if there is a legal investigation, and then the officer contacts the trusted third party so that they can link the doctors and the anonymous reference numbers so that they know what kinds of medication were prescribed by what who. The data collector collects the data, but the doctor's name stays anonymous, and this is the naive way of collecting the data. Basically, if you look at Dr. 2 and drug 3, then it is obvious that Dr. 2 prescribes drug 3 more often than other doctors, as well as Dr. 2 prescribes drug 3 more frequently than he prescribes the other different drugs. So it is easy to spot who Dr. 2 is, considering that many of the doctors know what kinds of medication are prescribed by their colleagues. So the better stealth approach is to replace the actual numbers by percentages, as well as ranking the doctors according to the total volume of the prescription medications dispensed. As additional safeguards, then rarely prescribed drugs and the new drugs shouldn't be displayed in the table set. Otherwise, it is again easy to identify who prescribed the rarely prescribed drugs or new drugs. Alternatively, we could just take out the doctor's information and just list the total number of drugs dispensed for medical research purposes. So far, we take a look at security at the storage level, but in order to achieve a complete security, we also need to look at how to achieve a security while a patient is visiting a doctor or while a doctor is transmitting electronic prescription to other parties. Actually, electronic prescription has been employed by some companies in the US since the mid-90s, and most of the structure is as follows. So again, patient goes to see a doctor who then prescribes the medicine, but then after that a doctor contacts a third-party clearinghouse, and the clearinghouse checks to see if there is any drug interactions, and if not, then the clearinghouse forwards the prescription information to the insurer. The patient then goes to see the pharmacist. The pharmacist retrieves the prescription information from the insurer, then dispenses the drug to the patient. One example system is Walgreens. Is a system developed by Walgreens, later purchased by IBM. The difference between this system, their Walgreens system, as opposed to the system we described before, is that instead of letting clearinghouse check to see the drug interaction, the clearinghouse in Walgreens' case doesn't check drug interaction, and instead they just check to see if the necessary field or is filled, if the and so on. And this is a good news for the pharmacists, because the pharmacists think their primary job is to check for drug interaction, so their job does not get taken by other third-party clearinghouse. On the other hand, Proximate developed an e-prescription system that is similar to the one we saw before, but instead of the clearinghouse sending the prescription to the insurance company, they directly fax to a pharmacy. However, e-prescription systems is adopted so rarely, and why so few? Well, it is expensive, no clear benefits to doctors, lack of interoperability, and low security, And the solution is, first, well, people need to get used to e-prescription. And in order for them to get used to them, then we have to make easier data entry using pen-based handwriting recognition system and so on. But more importantly, we need to have a tighter security. So what are the criteria for a secure e-prescription system? We need a revocability, non-refutability, linkability, and unlinkability. The first, revocability, means that although the patient's records must be confidential, if there is a legal investigation, then their records must be disclosed. Non-refutability means doctors and patients must not be able to deny the fact that they filled the prescription, or they saw a doctor, or they prescribed a medication. Linkability meaning that the patient might go to a different pharmacist. However, all the past prescription record of the patient must be linked to check the past drug interaction and so on. On the other hand, doctors' records must be unlinkable from the pharmacist because to protect doctors' anonymity. However, it must be linkable from the insurer so that the insurer can make a statistical analysis on what kinds of drugs doctor prescribes. So who are the players for the secure e-prescription system? As usual, we have patient, doctor, pharmacist, and insurer. But in addition to that, we have privacy officer, enforcement officer, judge, and certification boards and authorities. Privacy officer is the trusted third party that keeps the database that links the pseudonyms to the real identities. Enforcement officer has the authority to do the legal investigations. But enforcement officer has to talk to judge to get the right to revoke a patient's and doctor's confidentiality. Certification boards and authorities grant digital certificate such as that says patient is enrolled under a health plan and so on. So let's look at the protocol. So first patient contact the health plan. Oops. And when the patient contacts the health plan, the patient first sends a request to enroll in a health plan with a timestamp. It is signed by the patient's signature, and the signature is signed by the patient's private key. The patient also sends a public key, and the public key is used by the health plan to verify that the signature is really signed by the patient. Then after that, the health plan creates a pseudonym J for the patient, and it also attaches the public key of the patient and signs it using the health plan's private key and call it CJ as a certificate. So as a certificate of the patient's enrollment under the health plan. So the health plan sends the certificate back to the patient. The patient then goes to see the doctor with a certificate of enrollment for a health plan as well as a timestamp. The timestamp is necessary so that the patient cannot later deny that the patient didn't see a doctor. And again, it is also signed by the patient's private key. The doctor then prescribes the medicine but contacts the insurer or third party for the approval for the request. It is signed by the group signature key but not the doctor's private key. This is because if a doctor uses a doctor's private key, then it is easier for the third party to know who actually signed the key. However, if we use a group signature key, then the insurer only knows that one of the members of the group, member of the group, which is enrolled under the health plan, signed the approval of request and doesn't know which doctor actually signed it. So then the insurance company gives the approval with a prescription token, which basically talks about what kind of prescription is prescribed, and the insurer signs and sends the response back to the doctor. The doctor again signs the patient certificate, timestamp, and the response with the group signature again, and sends it to the pharmacist. Then the patient goes to the pharmacist with the timestamp and the pharmacist's name, which is signed. And implementation technicalities, we use group signature scheme as we said before, in which case we want to use dynamic group because the group members of the doctors enrolled under the health plan changes more or less often. We also want to use smart card. And then for the future research topic, wireless security is very important because it is becoming very common. However, it is very insecure. For example, with a wireless network card and with a laptop, it is easy to tamper the information. On the other hand, not all cryptographic primitives can be used by portable devices. For example, PDA doesn't have enough power to generate public keys. So the bad news is IEEE declared a standard for wireless security. However, it is proven to be insecure, which is bad. So the first solution is the risk management. We need to categorize what kind of security, what kinds of health information is more secure than others, and also we want to determine what kinds of security a given computing device can offer. For example, although PDA cannot create public keys, laptops are powerful enough for that. Another solution is to use quantum computing, quantum cryptography for encryption, quantum secret sharing scheme, fingerprinting, and quantum bit commitment. Quantum fingerprinting is used for authentication, and bit commitment is used for non-repudiation. And of course, quantum cryptography is actually, the devices are already sold, but the next two things is already still in theory. And the bad news is quantum bit commitment is proven to be theoretically impossible. So insights and reflections, e-prescription without borders. If I lived in the US and if I go to Europe, can we use e-prescription system and maybe e-diagnosis system to get the prescription from the US? And the other thing is all the cryptographic methods are insecure except for the one-time pad, but we need to physically secure the one-time pad. So if it gets stolen, then nothing is secure anymore. So in the end, we have to trade off how much security we want, and these are the references. Any questions? Yes.
Question. My question is with respect to slide number 22, and my question is that if we're going to go to all the trouble of putting together this elaborate e-prescription system, why would we not also in this paradigm give feedback to the doctor and let the doctor know that the patient has filled the prescription, given that we know that many patients don't fill the prescription?
Yes. So the question was, why do we go through all the details, details of going to the clearinghouse and insurers, instead just doctor giving the doctor managing the prescription information?
No, that's not the question. The question is, after we've gone through all of this process, why are we not giving feedback to the doctor to let the doctor know that the patient ultimately filled the prescription?
Okay. So the question is, why after all those things, doctors don't get the information as to whether the patient filled the prescription or not? Well, that part, actually, we might be able to incorporate that into the system. I haven't made a research about that things because it doesn't really directly relate to the security, but this is kind of interesting. Yes.
Does the clearinghouse act as a system that have access to all information of the patient? I mean, that can it do like access the also the deductive prescription and acronym?
Yes. So the question was whether clearinghouse has all the patient's past prescription history or medical history, and I think the answer is yes. And so the clearinghouse gets all the information from different pharmacists, and then since patient goes to different pharmacies, so one of the clearinghouse tasks is to combine all the information and store it into the computing device or something. And I think clearinghouse is one of the covered entities, so they have to.
So is that clearinghouse considered a database system or an expert system, or like what kind of?
It is more like a database system because they only, well, expert system use a database.
Yes.
So.
They have different features because they have decision making as well.
Yes, I think at this point it is just a plain database to go through all the list of patient medical history, and if there is some drug interaction with a particular patient medication, then it gives the beep and then the prescription is rejected. And I don't think at this point it's not really that deep, but in the future it might incorporate some expert system. Yes. Go ahead.
Are the security and privacy problems that you mentioned unique to electronic prescriptions, or do they exist in like the old way of doing things?
Please say it again.
Are the security and privacy problems that you mentioned unique to just electronic prescription, or did they exist in the old way of doing things, the old manual prescription system?
Yes, it does exist in old. The question was whether the privacy and security concerns that exist in the e-prescription system exist in the old prescription system. And the answer is yes, except that those privacy and security concerns that exist in the old prescription system is a subset of the more wider privacy and security concern in the e-prescription system, because e-prescription system handles the transmission of data on the wireless or wired networks. So it is more electronic. So yes.
Yeah, so it seems that in this scenario, the clearinghouses or the information stored in the clearinghouse is highly sensitive, meaning that confidentiality has to be enforced.
Yes.
The question is, who is the authority, or which authority takes ownership of such a critical part of the system?
It depends. The question was, the clearinghouse seems to be in charge of all those like security critical information, and who actually gets in charge of the clearinghouse. It depends on the country, I think, or maybe the states, but I'm not quite sure, but in the US it's probably private-wise, but probably in Canada it's public, just because like we have public healthcare system in Canada as opposed to private healthcare system where they don't really have wide coverage of insurance in the US. So yes.
Just one quick question is the algorithm that you went through, is that yours or was that from one of the?
Oh, it was in one of the references.
Okay. So I didn't get that, so you might annotate that on the thing. We're running out of time.
Okay.
Thank you very much.